Welcome back, everyone. Today, we're diving right into part 4 of our clinical coding explainer, focusing on mastering the diagnostic and toxicology CPT coding for blood alcohol concentration, or BAC. If you've ever found yourself struggling with exactly when to use a finding code versus a disorder code, or how to accurately bill for these toxicology tests, don't worry. We're establishing a strict clinical baseline today to clear all of that up. Let's jump in. Here's our roadmap for today's explainer. We're going to hit the lab baseline R78.0 first, then move into BAC coding with those Y90s, tackle the Y90 versus Y91 golden rule, break down lab toxicology CPTs, and finally, wrap it up with a quick preview of what's next. Let's get to it. All right, Section 1, establishing our lab baseline with R78.0. So what exactly is primary code R78.0? Well, it's strictly defined as a finding of alcohol in the blood. It's an objective fact, right? Triggered directly by a positive lab test. But here's the absolute crucial part. You only use this code in the total absence of a confirmed F10 diagnosis. That means no documented alcohol abuse or dependence yet. It's just a standalone clinical finding. Nothing more, nothing less. Now, the transition rules here are basically going to dictate your entire workflow. You use R78.0 right out of the gate when you get that positive lab detection. It's kind of like your placeholder. But, and this is a big but, you absolutely must pivot away from R78.0 and jump into the F10 substance use disorder series the second a provider officially documents a formal disorder, like abuse or dependence. Oh, and one more thing. When you do use R78.0, you'll see it's frequently paired with our next topic, the Y90 category codes. Which brings us to Section 2, BAC coding, or the Y90 codes. These Y90 codes are incredibly specific. They track blood alcohol levels in milligrams per 100 milliliters. It starts right at the bottom with Y90.0. That's for a level under 20. And as the concentration goes up, the codes just climb sequentially right along with it. Y90.1 covers 20 to 39, and it scales all the way up to Y90.8, which you'll use for levels hitting 240 and above. Now, what if alcohol is detected, but the exact level just isn't specified? That's exactly where Y90.9 comes in to save the day. But hey, knowing the codes is honestly only half the battle, right? Sequencing them correctly is where you really show your precision as a coder. You've got to stick to this strict sequencing guideline. Step 1. Always sequence your primary condition first. That could be your F10, alcohol-related disorder, maybe a specific trauma or intoxication. Then, step 2, you tag on the appropriate Y90 code as a secondary, supplementary descriptor. Just remember, Y90 codes are add-on codes only. They literally never stand alone as a primary diagnosis. They exist for one reason, to give us those extra quantitative details about the alcohol involvement in that primary condition. Moving on to Section 3, the Y90 versus Y91 golden rule. Listen, if there's a holy grail in alcohol coding, this is it, the golden rule. The path here is totally clear. You use Y90 when you have a cold, hard, objective, quantitative lab BAC level documented right there in the chart. If the lab gives you a specific number, boom, you choose Y90. On the flip side, you use Y91 when there's absolutely no lab value, and the coding is based entirely on the provider's clinical observation of intoxication. Let's put them side by side to really cement this distinction. Y90 is your go-to for objective quantitative data. It is 100% lab-driven. Y91, that one is entirely subjective and observational. Imagine the physician writes down that the patient has slurred speech, an unsteady gait, and smells strongly like alcohol, but they never actually drew blood or ran a test. Well, that clinical observation alone means you're going with a Y91 code. Keep this boundary sharp in your mind, and your coding is going to be rock solid every single time. All right, Section 4, Lab Toxicology CPT coding. Now, before we start slapping procedural codes on things, we really need to understand what specimen is actually being tested. These toxicology tests are primarily hunting for alcohol in blood, urine, and sometimes even tissue. That specific specimen, combined with the actual method they use to detect it, is exactly what drives our CPT code selection. Okay, let's walk through this crosswalk table together. Think of this as your master guide to CPT billing for alcohol labs. Right at the top, we've got codes 80305 through 80307. These are for presumptive drug testing. Basically, think of these as your rapid immunoassay screenings. They're giving you a super quick, qualitative yes or no for immediate triage. Next up is 80320, our definitive alcohol testing. This is the highly accurate, advanced quantitative method you use when you need that exact pinpoint BAC level. Then there's 82077, clinical ethanol testing. You're going to see this used specifically for blood, serum, or plasma ethanol quantification. It is incredibly common in emergency rooms and inpatient hospital toxicology panels. And finally, 80321 is for alcohol compounds. This is the one you pull out for specific testing of other toxic alcohols, stuff like isopropyl alcohol or methanol. Honestly, really understanding the functional difference between a rapid presumptive screen and a definitive down-to-the-decimal measurement is the absolute key to mastering this table. But wait, there's more. Beyond the standard tests, we also have these specialized toxicology biomarkers. And what's really fascinating here is the PETH test, phosphatidylethanol. This is a super powerful long-term biomarker. It actually reflects a patient's alcohol consumption over the preceding weeks. It essentially gives providers a historical window into the patient's habits, which is pretty amazing. Compare that to ethyl alcohol urine assays, which are much more immediate. Those are used specifically to verify very recent alcohol consumption. Both of these play totally unique, critical roles in a comprehensive clinical workup. And finally, Section 5, Summary Preview. I want to leave you with this final recap. And honestly, if you take nothing else away from this entire explainer, please remember this. The golden rule dictates your path. Quantitative laboratory data drives Y90, while subjective clinical assessment defaults to Y91. Just let the objective numbers be your guide, and only fall back on clinical observation when that lab data is nowhere to be found. Well, that officially wraps up Part 4. Next time in Part 5, we are going to be tackling Z codes, all those tricky counseling nuances, SBITR billing, and MIPS quality reporting. But before we go, I want to leave you with a question to chew on. If your hard lab data and your physician's subjective clinical notes completely contradict each other regarding a patient's level of impairment, which data set legally drives your final ICD-10 code? We are going to unpack those exact documentation conflicts next time. Like, share, subscribe to Decode Healthcare with Harshal.